the various mood disorders which we come across and we need to know about, and the management strategies for each of these disorders. They are quite common. If you talk about the lifetime prevalence of mood disorders, it comes around 20%, which is quite a huge amount. And they have high level of morbidity and mortality attached to it. And leave alone morbidity and mortality, if we compare the disability and the quality of life being impacted upon by the mood disorder, it is ranking quite high. As far as WHO estimates are concerned, it is one of the top 20 causes of causing disability because of a medical disorder. So, all the more reason to consider mood disorders as a significant psychiatric or a medical disorders in which significantly a person's life gets impacted upon. As you can infer from mood vis-a-vis or affective disorder, the primary or the fundamental disturbance is its change in mood or the affect, and this can be either towards depression or towards elation. In simple terms, depression is sadness of mood, or the patient does not feel good about life, about work, and when his mood is a bit above the normal state, it is elated, it is elevated, then we call it mood elevation, elation, ecstasy. These are all different descriptions of manic affect. So the fundamental disturbance in mood or affective disorder is a significant change in mood. And the second most important criteria, defining criteria for this change in mood should be, it should be a sustained thing, it should be a pervasive thing. By sustained change in mood or affect, we infer the change in mood and affect should be sustained over a period of time. It should not be lasting few seconds or few minutes. It should be there for few hours or few days on end. Then we call it sustained change in mood or affect. And it should be pervasive. What do you mean by pervasive? Pervasive means it should be, the change in mood or affect should be impacting upon the different spheres of functioning of an individual. Like a person, like for example, consider a student. He has different areas of functioning in college, in his house, in his friend's home, and in a social setup. So in all these areas, the change in mood or the effect which he is undergoing is affecting his functioning in these different spheres. So the change in mood or effect should be sustained, it should be pervasive. Then only we can call it a part of a mood or affective disorder. Most of these disorders tend to be recurrent. Hardly we see a case in which there have been one-off episode of mania or depression and thereafter the person was euthymic. That is quite rare. In most cases, the slight changes in mood and affect which amount to a diagnosable disorder of depression or manic category goes undiagnosed, and that is the reason most of the cases of mood or affective disorders tend to be recurrent. They can be divided broadly into two categories, unipolar and bipolar. As the name suggests, by unipolar we means those which are characterized by depression only. There have been history of only depressive episode, that's all. There's no history of any episode of mania in their lifetime. So if you go by the ICD-10 definition and classification of mood disorders, we have this alphanumeric classificatory system in which the F30 codes manic episode, F31 is bipolar affective disorder, F32 is depressive episode, F33 recurrent depressive episode, and F34 is persistent mood disorders in which we have dysthymia and cyclothymia. And then we have the other and the unspecified categories in F38 and F39. So if we talk about depressive episode, to diagnose a person with depressive episode, we need three important cardinal symptoms to be present. Whether it is a case of mild depressive episode or moderate depressive episode or severe depressive episode, the three cardinal symptoms have to be there. And these are depressed mood, which should be sustained and pervasive, as which I've already described earlier. It should be a sustained and a pervasive depressed mood. There should be loss of interest and enjoyment in previously pleasurable activities, which is also called anhedonia. there should be reduced energy leading to increased fatigability. The patient will complain that doctor, I am doing my usual activities but not at the same pace, at the same way I was able to do before this episode. I feel easily fatigued and I'm not able to, I'm feeling decreased energy because of this. So these are the three cardinal symptoms which have to be there in any depressive episode, be it mild, moderate, severe, whatever. And there are other associated symptoms of depression like tiredness only after slight effort, reduced concentration and attention, decreased self-esteem and confidence, ideas of guilt and unworthiness, bleak and pessimistic views of the future, ideas or acts of self-harm or suicide, and disturbed sleep and diminished appetite. So the clinical presentation shows marked individual variation. The clinical presentation varies from person to person. There are certain cases in which instead of the classical presentation of depression with retarded symptoms, fatigued, depressed, uninterested, inattentive, reduced concentration, the patient can also have motor agitation as one symptom of depression. Usually we see reduction in sleep or the decrease in the quality of sleep in most cases of depression. There are certain cases in which sleep may be increased also. So the symptoms are not hard and fast. They can show variation from person to person. And the mood change can also be masked by a number of features like irritability, like substance consumption, some personality issues like histrionic behavior, borderline disorder, and there could be exacerbation of pre-existing phobic or obsessional symptoms or hypochondriacal preoccupations. Usually these variations in presentation of depressive episode or presence of atypical, these are so-called atypical symptoms of depression, and if they are present, usually we see such presentation in extremes of age, like we see such presentation in very young age group, like the usual age of presentation of mood disorder is third decade. But if we see a presentation, say in a 12-year-old or a 13-year-old or in a 80-year-old person, in those cases, presentation with atypical symptoms is quite common. And the minimum duration criteria to qualify as depressive episode should be at least 2 weeks. So minimum duration required is 2 weeks. If a person is having these symptoms which are lasting below 2 weeks, then in such cases, a diagnosis of depressive episode still can be made, but there should be significant reasonability on the part of clinical assessment. Okay, the symptoms are there, the duration is less, but they are significant enough to disable the person, distress the person significantly, and impair his functioning in different areas of functioning. As I earlier told you, the lifetime prevalence of mood disorder is 20%, while depressive episode accounts for more than 95% of that. 17% is the lifetime prevalence of depressive episode, and the recurrence is in more than half of the cases. So the lowered mood can vary little from day to day and is usually unresponsive to circumstances or stimuli. So in other words, these are the somatic symptoms of depression. So usually you can get a short note or you can be asked in your viva voce examination, what are the different somatic symptoms of depression. So these are the different somatic symptoms like anhedonia, lack of emotional reactivity to normally pleasurable environment, waking in the morning 2 hours before the usual time, and depression getting worse in the morning when there is objective evidence of psychomotor retardation or agitation, loss of appetite, loss of sleep, weight loss, loss of libido. So these are the different somatic symptoms of depression. In ICD-10, we have a criterion of somatic syndrome. So in somatic syndrome, we qualify a depressive episode with or without somatic syndrome based on the presence of these somatic symptoms. The cutoff is 3 or more of these somatic symptoms being present in a depressive episode. If they are there, we call it depressive episode with somatic syndrome. So we have mild depressive episode, moderate, and then we have severe depressive episode. Here we have two varieties, one with psychotic symptoms and the other without psychotic symptoms. I believe you all are aware of psychotic symptoms per se. What do you understand by psychotic symptoms? Okay, just for sake of understanding, you should know delusion, hallucination, and a significant or a marked change in psychomotor activity of a person makes it psychotic symptoms. If a person has got two out of these three different changes or symptoms, we call it presence of or absence of psychiatric symptom. And then we have other and unspecified categories. In mild, out of the list of the symptoms which I earlier told you, like just to revise, this is the list of the different symptoms of depressive episode. These are the different symptoms of depressive episode, and out of these we have mild depressive episode. In this, two or three of these symptoms are usually present. And for mild depressive episode, as I earlier at the outset I discussed about the cardinal symptoms, these cardinal symptoms have to be there, and along with them two or three of the other associated symptoms should be there to qualify as mild depressive episode. And these moderate depressive episode, here individual with moderate depressive episode suffers from more symptoms. Just to give it a number, the number of the symptoms out of that list should be 4 or more than that. And again I would like to add, the presence of cardinal symptom is mandatory to qualify as depressive episode. Then we have severe depressive episode without psychotic symptoms. In severe depressive episode, the sufferer tend to show considerable distress. Usually he will have ideas or delusions of guilt, of persecution, of uselessness, and suicidal ideas are also quite common in severe depressive episode even without psychotic symptoms. But if the person has got some psychotic symptoms, we use the other criteria, severe depressive episode with psychotic symptoms. Here the psychotic symptoms could be delusions of sin, poverty, or imminent disasters, or they could be hallucinations like defamatory or accusatory voices, or rotting away, and depressive stupor. Severe ordinary social activities are impossible, and usually patients with severe depressive episode with psychotic symptoms tend to be the cases which need admission or need immediate management in the form of somatic therapy, be it ECT or RTMS. Then we have the category of recurrent depressive disorders. Like I earlier told you, there are different depressive episodes. Out of this, 50% are recurrent, and in these recurrent depressive disorders, they are usually characterized by repeated episodes of depression without any history of independent episodes of mania, a mood elevation or overactivity, and recovery is usually complete between these episodes. The lifetime prevalence is to the tune of 10 to 20%, with gender ratio of 2:1 in favor of females, and the risk of suicide is to the tune of 10 to 15%. We have another category of depressive disorder which we call seasonal affective disorder. Here the onset of mood symptoms is connected with a change of season. It has something to do with the duration of daylight, and usually depression occurring during the winter months, with remissions or changes from depression to mania occurring during spring. This description of seasonal affective disorder they were first described from the European countries, and therefore this winter onset of depression and occurrence of mania during spring is being described. And the one thing which is important to us is, if we are able to come across a case of seasonal affective disorder, we diagnose it like that, and we see a significant variation in the presence of mood disorders with the season change, then we call it seasonal affective disorders. And in them, apart from the other routine management of an affective disorder, we also depend upon light therapy. So light therapy has a role to play in seasonal affective disorder. Now these are the different types of recurrent depressive disorder, like recurrent depressive disorder, current episode mild, current episode moderate, current episode severe without psychotic symptoms, current episode severe with psychotic symptoms, and then recurrent depressive disorder currently in remission, then other and unspecified categories. Now we come to the other extreme. At one end we have the depressive disorder, and at the other extreme we have the manic episodes. So what is there in mania? If you remember the different symptoms which we discussed or described under depressive episode, you reverse those symptoms and you have the presentation of mania. Here a person's mood will be elevated or more than what is expected out of it in context of the current circumstances or the environment he is in. Usually a person can go into a state of elation, excitement, overconfidence, increased esteem when he gets some good news, like somebody tops in an examination, clears a very difficult entrance examination. Okay, in such a circumstance, his excitement and his elevated self-esteem is acceptable. But if it is out of proportion to the current circumstance, if it is significantly distressing to the patient as well as to the people around him, then we consider it to be pathological, and there we come across these categories of hypomania and mania. So just to name, we have manic episodes, hypomania, mania without psychotic symptoms, mania with psychotic symptoms, and the other and unspecified categories. Now, what is hypomania? Hypomania is a stage below the full-blown mania. Here, there is persistent mild elevation of mood for at least for several days on end. If you go by the strict definition, it is usually minimum of 4 days is required to qualify as hypomania. The person will have increased energy and activity and usually marked feelings of well-being and both physical and mental efficiency. And what will be the presentation like? The patient will be increasingly sociable, talkative, over familiar. He will try to make friends and behave as if he know a stranger quite well. His sexual energy will be elevated. There will be decreased need for sleep. Usually a person is normally sleeping for 6 to 7 hours. This person will be feeling energetic and full of life even after taking just 1 or 2 hours of sleep in the night. And the sleep is often present, but not to the extent that it leads to severe disruption of work. Now, this is the main differentiating feature of hypomania from mania. A hypomanic is expected to function quite well, even better than what he was doing when he was in normal mood state. But there will be no disruption of his work, and there will be no social rejection or any legal complication arising out of this hypomania. Most of the discoveries even happened serendipitously by different inventors and scientists have occurred during hypomanic episode. This is a theory being floated around to justify hypomania as a normal state, as an acceptable state, and something which we should not treat. But going by the medical logic, if somebody develops hypomania, there is all the more reason to be careful, observe the patient, and keep him under observation so that this hypomania doesn't progress into a full-blown mania. Because if that happens, then the person needs to be managed medically with treatment, with injections, and with ECT if required. So next we come to mania. When somebody from hypomania translates into full-blown mania, then the symptom duration should be minimum 1 week, and the mood which is elevated should be out of keeping with the person's circumstances, and it should be different from the carefree joviality, and there can be uncontrollable excitement which the person can exhibit. Elation is accompanied by increased energy resulting in pressure of speech and decreased need for sleep. And normal social inhibitions are lost, attention cannot be sustained, and he is quite distractible. His self-esteem is inflated with grandiose and over-optimistic ideas. Perceptual disorders may occur, may or may not occur. This is not necessary. The most fundamental thing which will be there in a case of mania will be elevation of mood, which will be expressed out in different forms. Like a person will become over religious, over familiar, over he will indulge in over grooming. He will spend hours in the parlor and getting dressed and changing his hairstyle and dressing in some odd fashion. So those things can happen. The individual may embark upon extravagant expenses. He will expend a lot of money on impractical schemes. He will distribute money and his goods and his food items, his household items among people recklessly. He will become aggressive, and so he will behave in a very inappropriate fashion, sufficient enough for the family members to be concerned and bring him for psychiatric consultations. And mania can happen with psychotic symptoms also. When these delusions, like these inflated self-esteem and grandiose ideas, get translated into full-blown delusions, we call it a psychotic symptoms. And in severe cases, grandiose or religious delusions of identity or role can be prominent. He will consider, okay, I am a god, I can do this, I can control the earth, I can control the weather, and things like that. So these things can be a presenting symptom in a patient with mania having psychotic symptoms. And because a patient, because of his mental state, because of his psychotic symptoms, there can be neglect of eating, drinking, sleep, personal hygiene. So he can be severely dehydrated, self-neglected. And usually in this presentation also patient can be brought to us, and such cases require urgent management. By urgent management, I mean management like ECT, RTMS, injectables. So because we require immediate result in such cases. And mania can be having mood congruent as well as mood incongruent psychotic symptoms. Means psychotic symptoms, the content of the psychotic symptoms will or will not be congruent with the mood state which is predominantly in the patient. Like a patient is of mania is having a non mood incongruent delusion of poverty is a mood incongruent delusion in a case of mania. So he can have mood congruent delusion or a mood incongruent delusion. Then we have bipolar affective disorders. In bipolar affective disorder, mood, we have depressed episode as well as manic episode. It is characterized by repeated at least one episode in which patient's mood and activity levels are significantly disturbed, and they suffer only from repeated episodes of mania. The first episode may occur at any age from child to old age, and the frequency of episodes and pattern of remissions and relapses are both very variable. The lifetime prevalence is between 0.5 and 1%, and suicidality is to the tune of 19%, with comorbidity with alcohol and drug abuse. There is a specific category of bipolar affective disorder which we call rapid cycling specifier, which identifies those patients who have had at least 4 episodes of major depressive, manic or mixed episode during the last 1 year. And these are the different categories of bipolar affective disorders. Bipolar affective disorder, current episode hypomanic. Bipolar affective disorder, current episode manic without psychotic symptoms, manic with psychotic symptoms. Mild or moderate depression, severe depression without psychotic symptoms, sev- severe depression with psychotic symptoms. Bipolar affective disorder, current episode mixed. Bipolar affective disorder currently in remission, other and unspecified category. Then we have persistent mood disorders. Here, the persistent mood disorders are characterized by persistent and usually fluctuating disorders of mood in which individual episodes are not specific, they are not discretely differentiated. It is a persistent change in mood which is there, which is lasting enough, not severe enough to being described as significant or specific episodes of hypomania or depression, and they should be lasting for at least 2 years. And in this, we have the category of cyclothymia and dysthymia, and then the other and the unspecified categories. In cyclothymia, there should be a persistent instability of mood. There should be a persistent instability of mood involving periods of mild depression and mild elation. And the instability usually develops early in the adult life and pursues a chronic course, although the mood may be normal and stable for months at a time. The mood swings are usually perceived by the individual as being unrelated to life events. Dysthymia represents a chronic, milder form of depression which does not fulfill the criteria for recurrent depressive disorder, especially in terms of severity. And the sufferers usually have periods of days or weeks when they describe themselves as well, but most of them they feel tired and depressed. It usually begins in adult life and lasts for at least several years, sometimes indefinitely. And the lifetime prevalence is approximately 3%, and it is more common in women. In the treatment of depression, we have different categories of antidepressants. We have tricyclic antidepressant, selective serotonin reuptake inhibitors, SSRIs. We have serotonin and norepinephrine reuptake inhibitors like SNRIs. So these are the different types of antidepressants which we have got, and their overall effectiveness is not more than 70%. So there are 30% cases in which any antidepressant will not be effective. In such cases, we have to go for other options also. There are certain antidepressants like metazapine, which we can use in cases in which insomnia is common, anorexia is there, because they have got a side effect of producing increased sedation and increasing appetite. Patients with lethargy, hypersomnia, weight gain, and lower level of tension and anxiety may prefer the less sedating medicines like bupropion, reboxetine, or stimulating SSRI. And there are other agents like EMAO, RIMA, they should be used, but they are used in refractive cases. And the drug trials, when you are starting an antidepressant for a case of depression, the minimum trial duration should be 4 weeks and maximum should be 8 weeks. When you have given a full trial of at least 6 weeks to a patient on a given antidepressant, then only you can say whether that antidepressant worked or not. And in such cases, only you need to switch over to another antidepressant. In partial responders, you need to augment the current antidepressant being in use with lithium or with triiodothyronine. In psychotic patient or a patient of mood disorder with psychotic symptoms, you need to add a antipsychotic, obviously. While for cases with anxious or agitation, you need to add a benzodiazepine along with this. Supportive psychotherapy can start along with the antidepressant. While for first episode of depression, the drug should be given for at least 16 to 20 weeks. That means around 4 to 5 months. Patients should be given a full course of antidepressant in the full dosage so that subsequent remission, subsequent episode doesn't come. The medication should be tapered gradually because many patients experience mild withdrawal symptoms. Patients with recurrent depression need long-term maintenance therapy to prevent relapses. We have another treatment modality in the form of electroconvulsive therapy. It is a treatment of choice for certain patients of mood disorders in which we have severe depression, there's high potential for suicide or any self-destructive behavior, and for pregnant women also ECT is a treatment of choice. There are other therapies like light therapy, phototherapy for seasonal affective disorder, which I earlier discussed. Sleep deprivation is a controversial sort of therapy for depressive disorder, but it is not very much acceptable. Now we have another treatment option in the form of repetitive transcranial magnetic stimulation. It is available at few centers in our country at the moment, and it is also showing a lot of promise as far as managing a mood episode or mood disorder is concerned. Now the treatment of mania. Here the treatment comprises of mood stabilizers, anticonvulsants, and antipsychotics. Among the mood stabilizer we use lithium, and in the bracket you are seeing the blood levels which are our target therapeutic levels which should be achieved with the dosage which we give. Like for lithium, the target blood levels are 0.6 to 1.2 milliequivalents per liter. For carbamazepine it is 6 to 12 milligram per liter, and for valproate it is 50 to 125 milligram per liter. And as far as anticonvulsants are concerned, gabapentin, topiramate, lamotrigine, they all can have been used in different dosages with some effect in mania. For agitated and psychotic patient, we can administer second generation antipsychotics like olanzapine, risperidone, aripiprazole, quetiapine, along with or without benzodiazepines. And ECT again is a treatment option in mania. So with this we come to the end of today's lecture, and with this lecture, the main aim was just to make you aware of the presence of mood disorders, the different types of mood disorders, the clinical presentation which they have, and how we differentiate the different bipolar and the unipolar disorders, the concept of persistent mood disorders, as well as the simple management strategies which we adopt in managing these mood disorders. Okay. Any questions? Any question which you have, you like to clarify, you can type in and I will reply. Any clarification, query? If there are no further queries, we can close the session. If there are no further questions, we can close the session. Okay. So we are closing the session. Thanks.